Hello, welcome back to another head-to-toe scanning video. Today we're going to be focusing on the interscaling nerve block with ultrasound. I'm Brandon Winchester, and I'm the co-founder of blockjocks.com and host of this video series today. In this video, we're going to be featuring the interscaling nerve block, which is almost exclusively used for shoulder surgery here at the Andrews Institute and elsewhere. It's used for both inpatient as well as outpatient major shoulder surgeries. In fact, the more major the surgery, the more likely that you're going to place a continuous catheter versus a single injection nerve block, like we'll talk about a little bit later. But really, that's the bread and butter reason why we use interscaling nerve blocks. We do sometimes encounter, even in the outpatient setting, some fractures of the proximal humerus, which is another place that we use the interscaling nerve block. But otherwise, it's pretty much the tried and true method, both historically with landmark-based techniques and more recently with ultrasound-guided techniques for providing optimal anesthesia after major shoulder surgery. There's a few considerations similar to the considerations that we mentioned in terms of who to avoid the nerve blocks for supraclavicular brachial plexus blocks. If you remember, supraclavicular brachial plexus blocks have a very wide range, depending on which study you're referencing, of incidence of phrenic nerve block. Similarly, interscaling nerve blocks with ultrasound have been reported a range of risk of phrenic nerve block, but generally speaking, relative to supraclavicular, it's typically about twice as much risk. When you're doing a traditional technique with a high volume placed with landmarks, the interscaling nerve block and phrenic nerve block were coincident. Essentially, you had 100% traditional incidence of phrenic nerve block. And although recent evidence supports the use of lower volumes to lessen the likelihood of phrenic nerve block with interscaling nerve blocks, the reality is that phrenic nerve block still happens a very substantial part of the time unless you're using a very, very low local anesthesia volume. So for all intents and purposes, if you have significant doubt about whether a patient with significant pulmonary comorbidity can handle an additional ipsilateral hemidiaphragmatic paresis, paralysis of that diaphragm, by virtue of the not definite risk of phrenic nerve block, but high risk of phrenic nerve block. If you have those concerns, this is typically a block that you might want to avoid, or in our line of work, consider sending over to the hospital and not being done at our outpatient center. So that's one of the things to consider as far as who not to do the nerve block for. As far as who to do the nerve block for, even for shoulder arthroscopies, which are not as invasive as a full rotator cuff repair or a total shoulder replacement, etc., even for shoulder arthroscopies, it should be seriously considered both in terms of hospital and ASC throughput, as well as overall patient comfort and satisfaction, to at least consider a single injection nerve block for these procedures. Typically, we don't do a lot of diagnostic work at our institute. In fact, nearly every shoulder surgery that's done comes with a significant degree of repair work that's being done. So we have in our practice a very low threshold for placing a continuous interscaling nerve block for the procedures that we're doing. So in the game of deciding who gets them and who doesn't, besides those occasional patients that have significant pulmonary comorbidity, really the vast majority of patients who are having shoulder surgery should get interscaling nerve blocks, and if you're having any significant degree of repair, they should have continuous interscaling nerve blocks. Probably better than any other nerve block in the literature. Continuous catheter versus single injection is very strongly supported for a number of reasons, most importantly, overall pain control and patient satisfaction. So we'll get started with the initial decision, which is simply which probe do you use. And like every other block virtually that we'll be talking about, it's a wide linear transducer. In this case, it's a 6 to 15 range, megahertz range frequency transducer, 6 being on the low end of the frequency range, 15 being on the high end of the range. And like I've said earlier, I usually just leave my settings right at the middle range of frequencies. I don't see a whole lot of difference in the images that I acquire if I'm using an adjusted setting for low frequency for deep structures or high frequency for superficial structures. So I will use a wide, high frequency linear transducer, leaving it right there at that mid range, or in this particular machine's range, it's called gen mode. As far as the depth and the overall gain that you're going to start at, you're typically, for an interscaling nerve block, going to encounter structures that are somewhat shallower than other nerve blocks. For example, we're going to be able to see this particular model's ultrasound anatomy at about 1.5 to 3 centimeters in depth. So typically you're going to start somewhere around 3 centimeters in depth and adjust accordingly depending on what you see. Now, we will be starting with a supraclavicular plexus scan, so you may consider in larger patients to start at a deeper depth, maybe 3.5 to 4 centimeters, or in really large patients, even starting in the 4 to 4.9 range. But on average, typically somewhere around 3 centimeters is all you're going to need in order to start your scan with an ultrasound-guided interscaling nerve block. As far as your gain settings, like usual, just go ahead and leave the gain settings at the native settings of the machine and adjust accordingly so that you feel like you're getting the target as bright as you'd like it. I tend to favor a little brighter target. I tend to favor a little more gain in my starting settings. So we'll go ahead and get started now by showing you some of the surface anatomy for an interscaling nerve block with ultrasound. Now, one of the most important parts of the decision tree for any nerve block, and interscalings is especially pertinent because there's a lot of people doing these in a couple of different ways. One of the most important first decision trees is whether to do it supine or to do it lateral. And especially since most of our interscaling nerve blocks are being done while for a continuous catheter placement, you have a lot more room back here to work with posteriorly if the patient's in the lateral position. I don't think it's necessarily easier to place the block per se in the lateral position, but I do certainly find it easier to place a continuous catheter, and I do especially find it easier to place the dressing at the end of an interscaling nerve block. So first things first, we'll place the patient into the lateral position, and as you can see in this big picture shot, you have a lot more room posteriorly now to work with. You don't have to worry when you put your dressing on about the bed interfering with the dressing placement. You'll have a lot of room to work with. Now, when you first position your patients, you're typically going to slide the pillow, as we've already done here, so that it's flush with the edge of the head posteriorly. You're also going to ask the patient to reach down and grab for their hip with their up arm. By doing so, they're keeping the arm nice and straight, and by kind of grabbing the hip, they're providing a little bit of self-traction of that shoulder. Now, despite that traction, occasionally you'll need to place the patient in a little bit of head-up reverse Trendelenburg position, which allows gravity to enhance that downward traction on the shoulder. What you don't want to have happen is a shoulder kind of shrugging up on you, which encroaches on your insertion, encroaches on your scanning. Generally, you want to have an open book where the neck and the shoulder are kind of like the angle of an open book as opposed to a closed book if that shoulder starts to shrug upwards. Worst case scenario, if you have a little bit of self-traction and you have the patient in the reverse Trendelenburg position, you can have your nurse or your assistant reach across and provide a little gentle traction on the wrist, making sure that that angle between the neck and the shoulder remains an open book. So we'll start our scan like we talked about in the supraclavicular scanning video. We start interscalings with the supraclavicular scan as well. Now remember, we're parallel to the clavicle, and we're going to rotate approximately 1 finger's breadth off of that clavicle and identify the targets of the supraclavicular brachial plexus. You can see on the ultrasound screen some of the anatomy in question. And as we pointed out in the supraclavicular scanning video, the first things, before you ever even begin to try to target the nerves, the first 2 things you're going to identify are the subclavian artery and the first rib. Subclavian artery here, the pulsatile structure in the mid to medial side of the screen on the right, and just deep to it with a little bit of adjusted tilt angle of the ultrasound probe, the first rib, the bright white line going straight across the screen. And just above that first rib is the cluster of grapes, trunks and divisions of the brachial plexus, superficial most of which is the upper trunk, somewhere around the 11 o'clock position relative to that artery is going to be your upper trunk. And remember, you can't tell the upper trunk from the lower and middle trunk really all that easily. You just know where, relatively speaking, it's the superficial most component of that brachial plexus trunks and divisions cluster of grapes. So before we show the ultrasound scan, I want to point out a couple of things regarding the part maneuvers. Remember, the alignment in terms of your slide, anterior to posterior, in terms of your slide up and down the neck is important. We start with an alignment anterior and posterior such that the subclavian artery is visible like we just showed you on the screen. And then from this point forward, our alignment's going to adjust in terms of your slide up the neck. You're going to slide the probe up the neck towards a more proximal position on the brachial plexus at the level of the roots. Remember, the supraclavicular is at the level of the trunks and divisions. The level of the interscaling is higher in the brachial plexus. Remember Netter's anatomy. It's higher in the brachial plexus at the level of the roots, namely the 5th and the 6th cervical roots. So, as far as tilt angle, you start with a little bit of a downward tilt angle, and as you're going up the neck, you're adjusting your tilt angle up the neck a little bit. So you're simultaneously sliding up the neck and tilting the probe as you go up the neck. And because you're simultaneously sliding and tilting, we call this the paintbrush maneuver, because it really is like sliding a paintbrush up and down a fence post. Up the neck, down the neck. Supraclavicular down the neck, interscaling brachial plexus up the neck. So on the ultrasound picture-in-picture screen here, down the neck at the supraclavicular level, up the neck, interscaling level, down the neck, supraclavicular level, up the neck, interscaling level. And I'll do that a couple more times here, pointing out the most important thing that you're going to want to identify, which is first that upper trunk at the superficial most component of the brachial plexus at the supraclavicular level, and identify it as sort of circles side by side. And as you go up the neck, there's two things I want you to really focus on. One is that the subclavian artery is going to disappear off the screen. That's thing number one, endpoint number one that you're looking for. Subclavian artery is effectively going to disappear off the screen. And two, the shape of the brachial plexus is going to narrow. The fifth and sixth roots are going to be formed by that upper trunk, and you know they're formed, you know you're at the root level when those cluster of grapes, those circles side by side, start to look like circles one on top of the other. We call that the stoplight sign or the snow cone sign, and you'll see that here in a moment as we scan up the neck. So keep an eye on that upper trunk, and let's scan up the neck. You can see the artery's gone, and the plexus has started to narrow. You can see now a stoplight sign. There's three circles, and she has a very classic stoplight sign. The fifth, the sixth, and the third circle is just essentially another branch of the sixth root. A very common mistake here is to call this the fifth, sixth, and seventh roots. In fact, it's the fifth and sixth roots, and the most common configuration is that those two middle and bottom circles represent two components of the sixth root. Now, identifying those roots, now that we've gone high enough up the neck, is only part of the target identification that we're going to focus on. But before we even do that, I also want to point out one caveat, one little pearl, and that is, now that we know the two things to look out for, one is the arteries disappeared off the screen, two is the nerves have narrowed, the plexus is now circle on top of circle, it's important to know when you've gone too far, too. So now we have a classic stoplight sign here where the fifth and sixth roots are right on top of each other. But what happens if we scan a little higher up the neck? What you see is the fifth and sixth roots start to separate from each other. Watch that fifth and sixth root. Fifth and sixth start to separate from each other. Down the neck, they're right on top of each other. Up the neck, they really start to separate. And all you see now is that fifth root at the top. You know when the fifth and sixth roots start to separate like that, you know you've gone too far up the neck. Essentially, it's time to make a U-turn and go back down to the classic stoplight position where the fifth and sixth roots lie right on top of one another, like demonstrated in this image here. So, a couple of other muscular landmarks to point out, coming from the right side of the screen, which is anterior, to the left side of the screen, which is posterior. A major muscular landmark to point out is the sternocleidomastoid muscle. It's this muscle that goes over the cross of the screen from anterior to posterior, terminates here, much more posterior than the brachial plexus, and then sort of loops down and anterior. That's one of the superficial muscles to to identify. And if you scan a little more anteriorly, you can see just below that sternocleidomastoid muscle a compressible vein. That's the internal jugular vein, the IJ. And just deep and medial in the classic configuration relative to the vein is the pulsatile carotid artery. And you can see, if I put color flow Doppler on, what that looks like. We'll move the color flow Doppler over both vein and artery. You can see that the vein is much more of a jugular venous pulsation. It's not truly just passive flow. You see a little bit of pulsation, but you see an arterial pulsation in that carotid artery, which mirrors the heart rate. If you're measuring heart rate on the screen, it'll mirror the heart rate. That's a good way to identify the artery, both by the pulsatility of the flow and also the non-compressibility. Notice if I compress, the vein gets compressed and the artery does not. So a quick little aside, being able to demonstrate the color flow Doppler of both the IJ as well as the carotid. Of course, when you're doing a nerve block, you always want to turn off color flow, so we'll go ahead and do that now. Generally speaking, if you're looking at the carotid and the IJ, you are way too anterior, so it's one thing to point out. If you're seeing any kind of pulsatility of major vessels over there, you're too anterior. It's time to start scanning posterior where you saw that brachial plexus much more clearly, like a stoplight, again here. All right, so we've just shown you the sternocleidomastoid muscle, which is a good segue to showing you both the superficial cervical plexus as well as the deep cervical plexus. Superficial cervical plexus, as you may remember from landmarks, is the hyperechoic bright white area just deep to, starting just posterior to the sternocleidomastoid muscle and running just under that posterior deep border of the sternocleidomastoid muscle. Occasionally we'll have to do superficial cervical plexus blocks for breakthrough pain in the recovery room after medial clavicular fractures. Rarely do we have to do this, but we have had some great success, and in fact we have a video of this on the blockjocks.com website of a rescue superficial cervical plexus block. The benefit of this is that you get some of those higher cervical roots above the fifth root that you get with the interscalene plexus block. One of the other benefits is that you don't typically get a phrenic nerve block when you do a superficial cervical plexus block. However, if you infiltrate along that deep border of the sternocleidomastoid muscle towards the anterior direction, as you get to about here, you can see some additional hyperechoic structures visualized just adjacent to that internal jugular vein, which is collapsible right here, and carotid artery. All this hyperechoic structures here, that's the deep cervical plexus. So sometimes people will do a block at this location to anesthetize for a carotid endarterectomy if the surgeons would like to do it awake with just gentle sedation. In our particular case, for shoulder surgery, we don't typically want to get near that deep cervical plexus because although it's not very clearly visualized, and frankly there's no real need to visualize it when doing a posterior interscaling approach, somewhere in that hyperechoic white, anterior to and slightly medial to the surface of that anterior scaling muscle, somewhere in that bright white is the phrenic nerve. It's probably somewhere around here, but just know that this is the phrenic nerve in this territory. This is where we're doing our nerve block, and it's real easy for local anesthetic, especially in high volume, to spread over the top of the anterior scaling muscle down into that deep cervical plexus to get a phrenic nerve block, which, as we talked about earlier, is one of the complications you want to try to avoid with interscaling blocks by staying posterior with your injection and by keeping your local anesthesia volume to a minimum. So the two important muscular landmarks that that interscaling plexus at the level of the fifth and sixth roots lie between are the anterior scaling muscle, this muscle belly here, and the middle scaling muscle, this muscle belly just posterior to the roots. And the middle scaling muscle, when taking the approach we're going to take, which is a short axis view of the target with an in-plane view of the needle coming in-plane along its length from posterior to anterior. This is an in-plane short axis technique where we'll literally go through the middle scaling muscle. Now there's two structures to be aware that exists in this proximity. The first nerve structure to point out is the dorsal scapular nerve, which lies right in the middle scaling belly. And as I scan up the neck, it becomes closer to the nerves, and as I scan down the neck, it becomes farther away from the nerves. That's an important structure to point out because it's something you need to avoid with your needle. But notice that structure is a little bit trickier to see than the roots. It's not as bright, and it also lies right in the path of a needle if it's coming from posterior to anterior oftentimes. And so one thing that we've adjusted our technique in recent months is that in the past we would do interscaling nerve blocks exclusively with ultrasound because you really don't need a twitch to confirm that your needle tip is properly positioned just between the middle scaling muscle and the brachial plexus. But because of that dorsal scapular nerve, and additionally the long thoracic nerve, which is usually not identified but visualized or at least present somewhere on the surface usually of that middle scaling muscle, because those two nerves exist and because they're in the typical path of the needle, dorsal scapular and long thoracic nerve, I think it's wise to not only use ultrasound for your guidance, but also leave a twitch monitor on. In our case, we just leave it on at 0.5 milliamps. And the benefit there is that in case you don't see the dorsal scapular nerve, or in case you don't see the long thoracic nerve, you might at least elicit a motor twitch, a posterior motor twitch with one of those two nerves, and therefore avoid potential injury. Because if you do elicit a twitch unexpectedly, you'll have the opportunity to stop your needle, pull back, redirect a little steeper, or pull back and redirect a little more superficial, and therefore potentially at least avoid a catastrophic motor injury to either the long thoracic nerve or the dorsal scapular nerve. So just some food for thought. Although traditionally ultrasound is felt to be very capable of providing excellent and safe results for interscaling nerve blocks without nerve stimulation, the dorsal scapular and the long thoracic nerves are two considerations for why you may consider continuing to stimulate. Even if you don't feel like it helps your success, it may overall still help your safety in your posterior to anterior needle placement. So the target that we're initially going to go after with this particular nerve block is the plane, the space between the middle scalene muscle and the posterior side of the brachial plexus 5th and 6th roots. So as your needle approaches in plane from posterior to anterior, you're going to feel with that blunt tip needle tip a pop as your needle tip gets through middle scalene muscle and lies just adjacent to that 5th and 6th nerve root. And when you feel that pop, and typically if you're using a dual guidance technique, that pop will be accompanied by a deltoid twitch or a biceps twitch. If you feel that combined pop and twitch especially, you know you're in the correct plane and you can go ahead and initiate your injection. So before we talk any more about the injection itself, we'll talk about the needle insertion, which of course has to precede the injection. So here's our general position of our probe. And remember, it's only about 1.5 to 2 centimeters deep for the nerve. So like we talked about with a superficial, relatively skinny patient for supraclavicular, a relatively skinny patient for interscalene will have the same principle. You won't have to insert as far away from the probe for a skinnier patient as you do for a larger patient. So generally speaking, if you're doing a single injection interscalene nerve block, you're going to insert your needle a little bit closer to the probe. I would still say though, 2 to 3 centimeters at the closest to the probe is going to give you a nice angle of entry where you're coming from posterior to anterior with your needle in plane. Now, that is a specific area where single injection versus catheter are going to differ. Because although inserting farther from the probe doesn't necessarily give you a better visualization of your needle because the target's already fairly superficial, it does give you more of kind of a pseudo tunnel, so to speak, of your catheter from the insertion site all the way to the target, which I think is going to give you a little better anchor of your catheter, preventing dislodgement, and it's also going to give you a longer distance with local anesthesia, that the local anesthesia has to leak back along the catheter before leakage happens at the skin. So I think a posterior, more posterior insertion site for a catheter is going to give you potentially lessened incidence of leakage and potentially lessened incidence of dislodgement, because not only is that catheter going to be anchored in the skin a little bit better and through that muscle with that longer distance, but the less leakage is also probably going to lessen the likelihood of dislodgement of your dressing, because dressing dislodgement is very highly related to whether the dressing got wet from leakage or not. So again, that's a place where a single injection in a catheter might vary. Another benefit of inserting a little farther from the probe, especially if you cheat and rotate your probe a little bit like this, is that your needle insertion is a little farther from the surgeon's sterile field, because remember, you have to put a dressing on at the end of this catheter placement. So if the surgeon's dressing is coming up to here, you're going to be fighting for real estate with that surgeon where your interscalene dressing comes close to overlapping with your surgeon's dressing. So anything you can do to cheat, including a little bit of a rotation and therefore additionally a little bit of an increased distance away from the probe of insertion, is going to make that insertion site a little further from the surgeon's dressing and the surgeon's sterile field. So a little tip and trick in terms of catheter placement. So with a single injection, a little closer to the probe, catheter, a little farther from the probe, and as the needle's advancing, you'll feel an initial, you want to first do a skin wheel, of course, like any nerve block that we do, but as the needle is advancing towards the target, you're going to feel a relatively low degree of resistance as your needle approaches the target. And with each fascial plane that you get through, though, you will feel kind of a pop or click as your needle passes through that plane. You don't want to advance too quickly as your needle is approaching, because if you do get a long thoracic twitch or a dorsal scapular twitch, you don't want to be in haste and get the twitch but not have time to stop and redirect around the target. You want to inject nice and slow and deliberately, so that if you do incidentally get a dorsal scapular twitch, you can pull back, inject more steeply, or pull back and advance more superficially below or above that nerve respectively to reach that target without potentially causing injury to the dorsal scapular or long thoracic nerves. So as I said, the target will be, the resistance will be low with the needle until you feel a pop getting through that fascial plane. Now there is a a component, a landmark that I did want to point out here now that I'm seeing it better. And that little arcing white here with the black shadowing below it is a transverse process. It's a bony transverse process coming off the spine. So typically when you see that, you obviously are not going to be able to put your needle through it because it's bone. So if you see that, you're going to want to go a little bit higher above it or a little bit below that bony landmark. And it's usually not too hard to avoid by going a little above or a little below. And worst case scenario, you can insert the needle a little bit closer to the probe so that you can take a little bit of a steeper approach and avoid inserting past that and avoid that bone being in the path of your needle. So just something to be aware of as the needle's going in. And once you've avoided all the landmines, once you've avoided the long thoracic nerve, the transverse process, and the dorsal scapular nerve, then you can safely reach your target by feeling a pop with your blunt tip needle between the middle scalene muscle and the brachial plexus. When you feel that pop, typically accompanied by a biceps or a deltoid twitch, you'll go ahead and initiate your injection. In our practice, we'll give a total of 15 cc's of 0.5% bupivacaine for our primary block and 5 cc aliquots. We'll give 5 cc's in the top, 5 cc's in the middle, 5 cc's at the deepest part of the brachial plexus, not necessarily in that order, but a total of 15 cc's is really all you need. And the endpoint that you're looking for, besides just the classic endpoint of the nerve stimulation twitch disappearing on injection, is you're looking for that brachial plexus to push away from the injection towards the right. And in so doing, while pushing that plexus away, you're creating space in that posterior compartment between the middle scalene muscle and the brachial plexus, because that is where you're going to go ahead and thread your catheter if you're threading an interscalene catheter. Typically what we do when it comes time to thread the catheter is we'll place our needle tip just adjacent to that 5th root with the bevel facing up, and we'll do what we call the Hickman flip. And as that catheter emerges out the needle tip, it hits that 5th root and starts to flip up on itself. It sort of takes a little bit of a loop, a little bit of a flip, and we enhance and accelerate that flip as we advance the catheter by steepening slowly the needle as the catheter is advancing, such that the tip is up here and the catheter flips on itself. And once you see that initial flip, that catheter sort of forms a loop on itself, which of course is much easier to see if you're watching one of our blockjocks.com interscaling catheter videos. But once that catheter flips on itself, we'll steepen and flatten the needle several more times and initiate 2 to 3 total flips, which leaves about at least 2 to 3 centimeters of catheter slack in the form of loops along that posterior component of the brachial plexus. Now I think that's very important, to leave some slack, to leave some loops of catheter along that posterior border, because this is a very mobile surface. If the neck turns, if the catheter gets tugged on, or any of the above, that catheter tip, if it's just a little bit of tip in that space between middle scalene muscle and brachial plexus, it's very liable to become dislodged, pull back into the middle scalene muscle, and once that happens, the catheter is going to be a failure. So with interscalene plexus blocks, I think it's very important that there be several centimeters of catheter slack left and deposited in that space between middle scalene muscle and the 5th and 6th roots. Now once you have those couple of loops in there, you want to slowly back out your needle, and when that needle tip is about half to 3/4 of the way out, you'll leave a few additional centimeters of catheter loops, catheter slack, subcutaneously, again, trying to avoid a pull on the catheter from the skin, displacing the tip of the catheter. Instead, it'll pull back on the slack on the catheter and lead to the tip remaining intact just posterior to that brachial plexus. And that's the very basics of the additional threading of a continuous catheter to complement your primary single injection nerve block. Now, when you're placing the catheter and sending them to either the floor for inpatients or sending them to home for outpatients, so we just told you a little bit about the optimal catheter placement. Unlike a lot of the other catheters that we place, where the general rule of thumb is to place the catheter just under and past the target, the interscalene plexus, because of the nature of the anatomy and because of the desire to stay posterior and farther away from the phrenic nerve, which lies over the anterior scalene muscle, and therefore easy to reach with local anesthesia spreading over the top of the anterior scalene muscle. Because of that phrenic nerve, there's a couple of adjustments in our technique that we utilize. We stay posterior. That's the first adjustment in our technique. We keep the volume lower. In our case, 15 cc's is our routine volume, as opposed to a typical 30 to 40 cc volume local anesthetic block for classic landmark-based interscalene techniques. Those are the two main important ways to avoid phrenic block: staying posterior and using less volume. The third way is more based on the catheter technique, and that is, similar to staying posterior with your initial injection, we stay posterior with our actual loops of the continuous catheter and start our rate at a little bit lower rate. In this case, we start at 4 cc's per hour, which is not only beneficial in terms of lessening your volume and lessening the likelihood that local anesthesia is going to travel over the top of the anterior scalene muscle and infiltrate the phrenic nerve, but secondly, they don't typically need much more than that, because the fact of the matter is that the 5th and 6th roots are very tightly bound together. You don't typically need much more volume per hour, in most patients at least, than 4 cc's per hour. So if you're willing to give patients the ability to dial their pump up and down, or willing to give nurses adjustability to dial the pump up and down on the floor, it makes sense to start your interscalene nerve block catheters at a lower rate. In our practice, we use 4 cc's per hour of 0.125% or 1/8% bupivacaine plane. Most other practices, more commonly than not, will use an alternative solution of 0.2% ropivacaine in their solution. To conclude the management of the catheter postoperatively, we typically leave these catheters in for 3 to 4 days on average. We have a pump that's filled for 550 cc's of local anesthetic. But for patients that have frozen shoulders, patients that are having vigorous therapy after a frozen shoulder, the surgeons typically request a 1-week pump where we leave the nerve block continuous catheter in for 1 week to enhance their ability to do therapy and rehab in that initial interim of the 7 days following surgery. So, but typically, more commonly than that, we'll leave the continuous catheters in for 3 to 4 days. So hopefully that was helpful. This concludes the ultrasound-guided interscalene nerve block and continuous catheter tutorial. As always, feel free to reach out to me with any questions. Appreciate you watching.